told you briefly my thoughts and my strategy. The first thing I want to find is the apex of the cheek. So I grab the lateral orbital bone and I find halfway on the bone between my two fingers. So that's my lateral orbital bone. I'm there. And then I think about this dropping vertically down the face. From here, I don't really often draw this horizontal line. I just have a look from the front and I think, where would the most beautiful apex of the cheek live in this scenario? So you've got these two vertical lines now. So head off the bed, looking into the camera. And the way I see it, I would want to create projection around here. I think this would be where I would want to create a really nice, feminine, beautiful apex of the cheek towards this way. Same around here. So this gives me my landmarks for where I want to create lift. And if we follow the zygomatic bone backwards, rest back, I like to draw on the underside and really palpate these bony landmarks, because ultimately a natural cheek will follow the underlying bone. And so this is my cheekbone. The same on this side. Just press, okay, and you will feel where the cheekbone lives yourself.
Sorry to interrupt this video. Hi, I'm Dr. Tristan Mehta, founder and CEO of Harley Academy, and I'm the one doing the injection that you're watching right now. I just want to take a moment to talk about our Injectables diploma. So Harley Academy is a higher education college for aesthetic medicine based out of the centre of London, UK. And over 3,000 medical professionals have gone through our academic programs to achieve a postgraduate diploma in aesthetics. They will get a title after their name, PG Dip Aesthetics. If you want to learn more about our programs, how you can gain your qualification and learn how to inject in a really structured, systematic and evidence-based way, then click on the details below and our team will be happy to have a conversation with you. Right, that's enough from me. Let's get back to the video. But if you are enjoying this and you want to see more content like this, please subscribe and click like.
So here we have an idea of where I will create my projection and where I want to create my lateral definition as well. Sit forwards. So the idea here is that we're going to create some projection of the apex, and then we're going to tail it off laterally, and we'll do this on each side. And this is now an important time to talk about an important structure in the midface, which is called the line of ligaments. If you think about the gem and how we're structuring each zone of the face, we have a key concept, and those key concepts are things that we think you should know or have some education about before starting to inject. And one of the key things in the medial midface, in the lateral midface, is our line of ligaments. And so I'm going to reference this now. So we have a zygomatic cutaneous ligament here. We have a lateral orbital thickening here, which is the insertion, the origin of the orbicular retaining ligament. We have this temporal adhesion here, and we have this mandibular ligament here. And so if you follow a line that connects each of these structures, so this is the temporal adhesion, temporal ligamentous adhesion, where basically the temple is all adhered to the skin, the fascial planes. We then have the lateral orbital thickening. We have the zygomatic cutaneous ligament, and we have the mandibular ligament. This line divides the midface into the medial midface and the lateral midface. And the reason that's important is because this is non-mobile and this is mobile. So if I put my finger here and give me a really big smile, my finger moves upwards. Relax. Smile again and relax. The reason is we have lip elevators here that all insert into the prominence of the zygoma, for example. And so this isn't medial to the line of ligaments and it's mobile. If you smile now, and relax, my finger doesn't move, and it doesn't even feel any motion underneath it. And that's because we are in the so-called fixed midface. And what this means is that generally, when we're injecting this side of the line of ligaments, it's okay to be superficial. It's okay to be injecting just underneath the skin if we want to create some definition like this, or in the preauricular area. And it's okay because when the patient smiles and expresses, it's not going to move around. But if you inject medial and you start to inject superficially too much, and give me a big smile, you will start to see movement and unnatural flow of facial dynamics with the filler. And so the line of ligaments tells us two things. First of all, that we can inject superficially if we want to. Okay, we can also be deep here if we want to create deep structure, but also that we have to be careful about injecting superficially medial to it. The second thing is that there's been a study which shows that if we first of all inject laterally, it means we actually need less volume medially further down the line. And so that's why we say when we're injecting, we start lateral and move medial. So how am I going to treat the midface in this scenario? I'm going to combine those concepts into a strategy, which means that I'm going to treat the apex deep, okay? Because this part of the apex, we have the deeper fat compartments, the SUF, and also the pre-periosteal fats. And then I'm going to tail my cannula treatment off laterally superficially, and that should give us a nice enhancement to the apex and the tail of the zygoma. Let's do some cleaning. And if we can have now another mil of Revanesse contour. Mm-hmm. And maybe Max, do you want to talk about, because we've got two different types of, I'm going to do a cannula treatment for the apex and the zygoma. Yeah. And obviously we can be in different depths in the cheek, right? And this time I want to show the deepest plane and how we inject that with a cannula.
Yeah. So in that deep plane, particularly in this more mobile area, anterior to the line of ligaments, it's actually quite difficult to differentiate between true being in the SUF and being in that pre-periosteal pain in that, what is also known as the pre-zygomatic space, or that fatty layer just underneath the pre-periosteal space. Actually, clinically, I don't know what you think, Tristan, I don't think, when you're with the cannula, it makes a huge amount of difference clinically. When we come more medially for a tear trough treatment, I think then it makes more of a difference what layer we're skirting in. But in terms of adding projection on the apex of the cheek, I think the language is more about the technique. So when you're with a cannula and you pop through either the SMAS or orbicularis oculi and then flatten out straight away, we call that SUF. But then if you're coming down with a needle, particularly if you're coming in at an angle with that needle so that your bevel is facing down, then technically that's more the pre-periosteal fat.
Absolutely right. So that with a needle is how we are going to be able to differentiate between those targets. And Max is completely right in that clinically, whether I treat it in the SUF or in the pre-periosteal fat with a cannula, it's hard to say how much we would notice. In this case, though, I do want to illustrate the difference between those different depths. And I'm going to do this through an entry point facing towards the tail of the zygoma, the zygomatic arch. Little scratch. Good. Okay. And let's talk about these depths that Max has just talked us through. So we go through the skin. We're in the subcutaneous fat. We see some tethering there. This is layer 3 of the face. And we go underneath layer 3. You'll see a pop there. This is now in the SUF. And this is an important target which loses volume with aging. However, there is another layer, and you will feel another depth you can go into. This is the surface of the prezygomatic space. And this surface is another fascial plane that comes down from the temple and is a midfacial extension of the superficial lamina of the deep temporal fascia. And we can inject again in a deeper depth, even still. Now, there, it's just gone. And so here now, I am in the pre-periosteal fat. This is truly gliding onto bone. And in this depth, we can create very deep projection. Particularly in patients where they have malar edema, this would be a really important way to learn how to inject the cheek apex, if you wanted to at all. And I'm just injecting 0.3 mils of Revenous contour down into this deepest depths where I think I want to create my apex of the cheek.
I think as a general rule of thumb, it should always feel smooth, that glide plane. Unless you're subcutaneous and trying to do a more superficial treatment, when you're in any of those deeper spaces, you don't feel that resistance. And if you do feel that resistance, you're probably in between layers. You're injecting into the mass or into the muscle, and then just take a moment and find your depth again.
Yep, agreed. Now, this is now relevant for our line of ligaments. I'm coming back into the subcutaneous plane, and this is the depth now that I want to do the rest of the treatment. I don't want to stay deep. I don't need to stay deep. I actually want to create some surface change to the zygomatic arch, and I can do this by tracking my cannula in the subcutaneous plane through the same entry points and following the bone. So if I now move all the way back here, I can inject just a touch, a hint of definition to make this look even more feminine and elevated at the lateral zygoma. Noticing that this will not move on expression because we are lateral to the line of ligaments. So in combination, deep projected apex, but superficial zygomatic arch, in combination give this very, very natural appearance to the cheek. And let's take a look. If you lift your head off the couch, look into the
Very nice.
camera, and that's really, really changed, I think, from one side to this side, which is quite a dramatic shift to the contour of the cheekbone itself. Head up. Straighten. Yeah.
And even the nasolabial folds, they weren't much of a concern. It seems they weren't that deep before, but now they're even more shallow.
Perfect. So I'm going to get that side, the other side done now. Good. So I take my markings off because I can appreciate where I would like to identify the apex of the cheek, and I can feel where I want the lateral zygoma to be, but there's no harm in drawing on the structures again if you needed to. So let's try this, let's demonstrate this one more time. We're in the subcutaneous fats. We're going to push through layer 3 now, sometimes with a little help. If you're using a larger cannula, like a 22 gauge, it's more blunt, and so it's a little more challenging to push through some of these layers. Okay, so that's in the souf. And then there's a second perforation. There. Mm-hmm. And now we are truly gliding onto the pre-periosteal fat. And I'm going to inject 0.3 in this deepest plane of the midface.
And the reason we're using a 22 gauge cannula rather than a 25 gauge or even smaller is purely safety. We're always balancing the size of the cannula to the safety of the treatment, the risk of going in a vessel, with patient comfort. And certainly in the midface, which is overall a comfortable treatment anyway, a 22 gauge cannula is very comfortable and also very safe.
Yep, absolutely agreed. On the way out now, staying in the subcutaneous plane and then finishing off my treatment in this layer 2, following the bony zygomatic arch that I feel between my fingers, and creating this surface level definition to enhance that lateral projection, give that very feminine contour to the lateral zygoma. Great. You're doing really, really well. Gabriella, how are you doing?
Yeah, not bad, thank you.
Okay. What we don't want to do is flatten this really nice deep projection. So what we can do is we can use a rolling motion like this just to help shape the underside of the filler. I don't want to squash this lovely deep projection that we've created. So by doing this, we can create even more enhancements. So, take a look now. Now we're getting somewhere, aren't we? The next thing we're going to treat is the tear trough, okay? And the tear trough, if we just remind ourselves of the important anatomy here, we have the origin of the orbicularis retaining ligament identified by this bony margin, okay? This is our superior aspect of any treatment that we're going to do in the midface. And then look at the limbus, the medial limbus of the iris. I like to draw a little arc coming down from here, which then denotes the zygomatic cutaneous ligament. And the tear trough is a really important structure for us to appreciate anatomically. If you come off the bed a little, I want injectors to appreciate the difference between this line here, okay? This line here is not a tear trough. This is something called the nasojugal groove, and it's formed at the superior pole of this nasolabial fat pad. And so patients will have a groove here as a natural endpoint of the fat cushion that lives here. And that's often confused for a tear trough. If injectors try and fill this little groove, they will actually end up making the under eye worse. What they need to appreciate is the actual tear trough is the gap between this nasojugal groove and this ligament as it inserts medially called the tear trough ligament, which is part of the orbicularis retaining ligament. And so we're injecting into this very tiny space. The tear trough is between those two lines. In this compartment, technically, in this compartment, we're in the SOOF. But as we start to age, the fat pads drop off the zygoma and we reveal the bony surface underneath. And that's why we get this area called the palpebromalar groove, which is treatable with filler as well. But we're not here, actually, the SOOF, as we age, slides down like this. And so we've exposed this bony margin, which is our palpebromalar groove, which we can also treat with filler. But technically, this is not tear trough filler. Only this here is the tear trough. So I'm going to treat all of that today with Revenus Revise. Make a little entry point at the intersection between the subnasal line and the lateral canthus. That gives us a nice entry point here. From this entry point, we can navigate subcutaneous. Just open your eyes for us, look upwards if you can, See that dimpling? We're just going to push through there. Now we're in layer 4. Well done. And we can just appreciate where the tip of our cannula is. This is the depth it looks like when you're in the right depth. Okay, you can't see the outline of the cannula really clearly. That would be too superficial. And I'm doing little micro aliquots to smooth the transition. Note that there isn't a significant hollowing.
Yeah, yeah.
So this is just a blending type approach.
I often find in the under eye area, just really small changes make quite a big difference, because when you're having a conversation with someone, it's really your eyes that they're looking at. And really subtle improvements just make you look more refreshed, more awake. I even find that people will respond differently to you if the eyes are treated well.
Perfect. So that is now all I would want to do, just to blend that lid to cheek transition. But I've obviously got this groove more laterally that I want to restore volume into. And to do that, we're just going to make an entry point overlying the zygoma.
What we learnt in aesthetic medicine even 1 or 2 years ago is now outdated. Why? Because aesthetics is still a relatively new science, and the research underpinning our work, particularly our understanding of anatomy, has advanced significantly. Hello, I'm Dr. Tristan Mehta, founder and CEO of Harley Academy, and I want to introduce you to GEM, the Global Evidence Matrix. GEM is a dynamic, evidence-based framework that gives injectors a clear, consistent guide for safe, effective treatments, all grounded in science, not in corporate sales pitches. GEM combines clinical research, anatomical knowledge, and injector expertise, and it's always updated with the latest evidence. Think of GEM as your interactive map for facial aesthetics, guiding you through every step from technique to product choice. With GEM, you're not just injecting, you're working at the forefront of medical aesthetics. Join us in setting a new standard for safety and results.
Laterally, the orbicularis retaining ligament becomes multiple lamina of connective tissue, and there are little fat divisions between those lamina, and so this is treating technically an anatomical target called the interlaminar fat, or the intralaminar fat. And we're going to again get to the right depth, little pop, and I'm treating now the groove. This is sensitive. If I go too far towards the eye, the patient will tell me, because I've noticed that in this area, if you inadvertently push up against the ligaments, it's uncomfortable. Total of 0.3 has been used. Every time I'm going in, I'm doing a tiny micro droplet of product. That's it. That's all I want to do for the infraorbital region. But let's take a look. If you sit forwards. Lovely. So we can really start to see the blending, very youthful transitions that are appearing under the eye. Can you see? Are you happy?
Yes, I am.
Okay, let's do this side as well. So what do you think common mistakes people make with the under eyes are, Max?
Probably overfilling.
Yeah,
Actually,
yeah, I agree.
Often a result that looks fantastic on the day is a little bit overfilled, because as that hyaluronic acid draws water towards it, even in products that say they don't swell, you're always going to get a little bit of that hydrophilic, hydroscopic response to it, and then a couple of weeks later, you're a bit puffy. So
yeah, it's always, you've got to give it room to swell and attract that water. So we always undertreat.
And also understanding that it's normal to have a little bit of a transition between the cheek and the lid. Nobody, even kids aren't completely smooth there.
Absolutely.
We're just looking to soften that slightly so that it's a bit less jarring, not eliminate it completely.
Agreed. There's also various factors that can complicate the tear trough, and we outline this in the infraorbital section of our GEM framework, but there are complex presentations that beginner injectors might think there is something that's treatable when it's not. For example, if there's lots of pigmentation under the eye, that's not a volumetric problem necessarily. It can't be significantly improved. If there's associated malar edema, if there are significant eye bags or pseudo prolapses of the intraorbital fat, all of these things can make presentation more complex.
That being said, if someone does have concurrent hyperpigmentation with true hollowing, then actually sometimes by improving that hollowing and improving the light reflex under the eye, even though you're not doing anything directly for the pigmentation, it can still make the under eye area look brighter.
Yeah.
But you need to examine, try and take that pigmentation out of the picture completely and examine the hollowing for what it is. A useful question I find is if a patient can put under eye makeup on or under eye concealer on, and that solves all of their problems, it's almost always either going to be pigmentation or thinning of the skin and seeing that muscle shining through. If even with makeup on you see a little bit of hollowing, then filler really is the only thing that's going to get on top of that from a non-surgical point of view. Lovely.
Perfect. Okay, final treatment in the midface sequence is going to be to just create some volume in this lateral cheek, this preauricular area, which is not only going to support the lower face, but it's also going to help some of the transitions of the hills and the valleys across the lateral face. We're conscious I don't want to remove or reduce this beautiful new contour across the cheekbone, but you will see that it doesn't really change a huge amount of the surface level volume. It's more of the structuring effect it can have. So turn this way. So I'm going to fan some product in now. So we're learning a lot about depth control here, and maybe you could talk a bit about what we see on ultrasound studies in relation to filler going too deep in this region, Max.
Yeah, so underneath this whole area here, we've got the parotid gland, and it's really important to be able to always see the outline of your cannula and know that you're subcutaneous. This is the opposite of what I said earlier with those deeper fat pads, where if you're in them, you tend to glide smoothly. Here, you are going to feel that resistance, and that's fine. But always make sure, as you can see now, that the cannula is nice and clear. Because what we do often see is, not necessarily with patients reporting any problems, but when we're scanning faces, we're seeing that there is filler material, even from years ago, sitting within the parotid gland and within the overlying fascia as well.
Yes. So how can we, so I think one of the things that I read is sudden loss of resistance is a warning sign.
Yeah.
Doing great. So that's that side done. Okay, so this is a really good one to see on camera, because hopefully what we'll notice is that we haven't changed that lovely projection of the cheekbone. But what we have done is look at the jawline on this side and look how much we've managed to lift it just with 0.5 ml of filler. It's now no longer, it's more tapered. Okay, if we look at where the weight of it is here compared to where it is here.
Very nice.
So let's do the same on this side. Head back, all the way this way. Thank you. How are you finding this treatment, Gabriella?
Yeah, not bad.
It often looks more uncomfortable than it feels.
Yeah.
You do feel it in your ear a little bit.
Have you got someone at home that's going to notice what you've had done, or?
Well, my daughter, but I doubt she'll notice because children never do they?
Well, they can be quite brutal sometimes, can't they?
Indeed, yeah.
So, to Max's point, you'll notice when my cannula, I feel like I'm going a little too deep. I'm always going to come back to this point where I can make sure that I'm in that subcutaneous, subdermal depth. And when I want to change direction, I'm almost having to come out completely. A big mistake people make is trying to change direction when they're already halfway in. And then they're just making more and more tracks down the same pathway.
But what you're not doing, Tristan, is injecting all along that pathway. Otherwise, you'd end up with that big collection of filler right by the entry point.
So I stop injecting here.
Yeah.
And this will get some treatment, but I'm not repeatedly treating the same path over and over again. And that prevents nodules.
One thing I see quite commonly with trainees is almost being a little bit too delicate in this area. You do need, particularly with a 22 gauge cannula, a bit of force to get through those little adhesions and to subside them. And to get all the way back to the ear, it's often more comfortable to use a little bit more pressure than you think.
Right then, so this is our midface and under eye and temples all done, okay? I'm really happy with that result.